Okay, welcome to Medical Grand Rounds. There is a small and select crowd here and lots of fantastic food. If anybody's debating whether to watch on Zoom or be in person, we're all still getting used to this strange new normal, but we're here hybrid in HSW 300. I'm Bob Wachter. I'm chair of the Department of Medicine. We're really pleased for you to join us today. The ground rules, you know, if you're watching us in person, there'll be time for questions at the end. If you're watching us on Zoom, just type a question in the Q&A box and we will try to get to it. Closed caption is available if you're on Zoom, and CME is available right at the end. And so let me introduce our speaker. Oh, by the way, for those who are here, masks are not required, but recommended and difficult to use while you're eating, so understand. Very pleased to introduce Andy Bindman. Andy is a dear old friend. He's also now Executive Vice President and Chief Medical Officer for Kaiser Permanente. There, he's responsible for quality and outcomes and equity and care delivery and research related to all of the same. He also is KP's executive sponsor for their now newish medical school based in Southern California. Look forward to hearing some more about that as well. Andy is a longtime friend of and faculty member at UCSF, where he was for 30 years violating the "You Can Stay Forever" mantra. He is a world-known researcher in health services research and outcomes and health policy, having published more than 200 articles. He has also advised the federal government for the House Energy and Commerce Committee and Department of HHS with a lot of input into Obamacare. And for the last years of the Obama administration, he actually ran the Agency for Healthcare Research and Quality, HRQ, which is the main federal agency that is in charge of trying to improve the quality of care for all Americans. And he graduated from Harvard and then Mount Sinai School of Medicine, and then came to UCSF as a resident. He was a Robert Wood Johnson Clinical Scholar at Stanford University, actually with me. He's received many, many honors, including election to the National Academy of Medicine, the Association of American Physicians, and there is a chair in general internal medicine and health policy at UCSF that is currently being searched for, but it is the Bindman Chair, which is evidence of not only Andy's accomplishments, but his generosity. So, Andy, we are thrilled to have you. So this is from UCSF to Kaiser Permanente, what's different about an integrated health plan and delivery system, and look forward to hearing it and talking. Thanks.
Well, thank you, and what a pleasure to be able to come back to UCSF. The only thing I'd forgotten about here was how challenging the parking was, but everything else is wonderful and lovely, as always. And so nice to see you, Bob, and those of you who were able to join here today. It does feel like a lovely homecoming to be able to come back to UCSF and to be able to reconnect with friends. So Bob reached out around my new role at Kaiser Permanente and asked if I might come share and give a little insights about what life is like in that delivery system that might provide some ways of thinking and contrasting and learning together about different ways of doing things. It's very similar to when, and Bob will recall this, when I was a junior faculty member, I had the great opportunity to take a sabbatical year in the UK, where I learned about the National Health Service. And what I would say about those kinds of experiences when you move into a different system is that not only do you learn about that new system, but it gives you insights into what you sort of took for granted about your own system. It's kind of like that joke that people make about, you know, when the two fish pass each other and one says, you know, how's the water today? And the other fish says, what water? You know, that it's very hard to notice your own environment until you step out and see what can be different. So anyway, I hope that this is helpful in that regard. So a little bit about my personal journey. Bob mentioned it. I actually was at UCSF a total of 35 years between house staff training and faculty time and so forth. So have a lot more direct knowledge from the UCSF side. I've been at KP Now, for about 18 months, I was joking with Bob when I came in that I was asked to be the chief medical officer. I felt like I've been the chief COVID officer because, of course, 18 months has been very much in the midst of the pandemic. I've been trying to see if I can get dog year equivalents, that maybe 18 months times 7 years, maybe I'll get a little more. But in any case, you can see it's a little bit weighted toward UCSF. Did require a little bit of a change in location, but not extraordinary, going from San Francisco to Oakland. Probably the hardest change is the third one listed there, moving from the Zoom platform to the Teams platform. At my age, learning a new platform is not an easy thing to do. So anyway, still stumble through that. But my role, as I referenced, did change. I had been really honored and privileged to be a professor in the Department of Medicine for so long at UCSF, and hung up the white coat, so to speak, to become the chief medical officer at KP. And I'll talk a little bit more there about the role. And I guess what I would say is, yes, I do have still responsibilities related to some of the work that goes on at research at KP, which is quite robust. But really now I have moved much more into the space of implementation and really trying to think about how do we take the lessons of research and make that actionable on a population level. And I think, I know from as I was in the latter part of my time here at UCSF, that transition is underway here in many cases too, as people are thinking about not just harnessing health services research for learning purposes, but how do we make it actionable to change our own backyard, to improve the care of our own healthcare delivery systems. So a little bit about KP it's one of those things where my own experience was, okay, it's nearby. I see the signs and so forth, but I didn't really know some of the even basic structural details about it until I started working there. So KP is pretty big. It's a very large health plan and integrated delivery system. Annually, it's $93 billion, so large enterprise. 12.5 million members across the country. I'll show you a little bit more about where we are in a moment. Over 700 medical offices, 39 hospitals, most of those hospitals here in California. 23,000, more than 23,000 physicians. As I'll describe a little bit more, the medical groups are actually somewhat disparate in the different regions. And as a result, for example, you're probably most familiar with the Northern California Kaiser Permanente. That is the original place where Kaiser Permanente was born. In fact, it was tied to the Richmond shipyards. So that was the original location. But the Northern California Kaiser Medical Group, which goes by the lovely acronym that it took me a while to translate, TPMG, which stands for the Permanente Medical Group. All the other ones in the different regions are labeled by their regional location, like Kaiser Permanente, Southern California, and things like that. So Northern California is where this all started. The Northern California and Southern California medical groups as distinct groups are #1 and #2 in the country in terms of the largest medical groups in the country. So it gives you a sense of something that is relatively unique in Kaiser Permanente. The other thing that I think is not always understood or appreciated is just how large the research activities are at KP. Just at the end of 2021, we currently had active over 1,700 research studies. They take on a different flavor than what you might see here at UCSF, which has both extraordinary strength in basic science as well as translational work and population health and so forth. KP is really oriented toward that population activity, and so that many of the research studies are very much aligned with the clinical operation work, and I'll touch on that a little bit more as well. And then over 200,000 employees in the organization, many of them represented by different labor unions. And there's a strong history of KP with the labor movement, in part related to its connection with the shipyards and so forth. any case, that gives you some sense of the scale. And this is the location of where KP is around the country. Its largest footprint is in California. And you can see that there's about 4.5 million members in Northern California, a similar size in Southern California, then in the Northwest, mostly around Portland, up in Seattle area. The Washington State is a relatively newer part of KP. Some of you may have heard of Group Health Cooperative. That was a separate medical group, and it became part of KP several years ago. KP acquired Group Health. So that is the presence of KP up in Washington State. In Hawaii, and then Colorado in the Denver area, Georgia, mostly around the Atlanta area, and then Mid-Atlantic, which I believe is the fastest growing part of KP around Washington, D.C., Maryland, and the Virginia area. Now, you probably have some general understanding of the model of KP, but I think it's helpful just to kind of understand some key components about what's integrated about it. So first of all, from a member perspective, and I think that's first of all one of the language differences that I've noticed since going to KP, that we talk very much about members as opposed to patients. I mean, we do of course have people that we're taking care of in a clinical sense, but it is a membership organization, and members basically come to KP through a few different pathways. They can either do that individually, so they can, for example, an individual could purchase health insurance through Covered California. They could also choose as a Medicare member to come to KP. But there's also, just like all of you who are employed by UCSF, you can make a selection as through your employer to be able to choose KP. And there are many large employers who make KP the available health insurance coverage to their employees. So then either the individual or through the employer, payments are made to the Kaiser Foundation Health Plan, as shown there up at the top. Kaiser Foundation Health Plan is a nonprofit plan. It then has it also has as part of its ownership the hospitals of the Kaiser Foundation hospitals, also a nonprofit entity. And then it contracts with the Permanente medical groups. And each, again, of these groups is distinct in their geographic area. And then the Permanente medical physicians basically practice in California, for example, in Kaiser Foundation hospitals. But in some of the other regions, Kaiser has affiliations with hospitals that they do not own, but that they basically do the equivalent of renting space and forming relationships where then Permanente physicians care for patients in the Kaiser health plan. So that model of using non-Kaiser owned hospitals, for example, exists in Colorado or in Mid-Atlantic or Georgia and things like that. And some of the partners that we work with, so in the Georgia area, for example, our affiliated hospital is Emory. So that there is those kinds of relationships form. And the other key thing I guess I'll point out here is that basically money comes in through different sources from the members to the Kaiser health plan, and then Kaiser as a health plan turns around and provides essentially through its medical service agreements a fixed budget to the physicians to be able to care for their defined population of members. So rather than those physicians turning around and charging fee for service to the health plan, basically they've been prepaid on a budgetary basis to provide that care over time. So here's what I want to sort of highlight as I think kind of a key aspect of what I would describe as a little bit of the secret sauce of what I think allows KP to be innovative and to do what it does that is perhaps different in some cases than other kinds of health plans and its relationship with delivery systems. I think because of the budget process that I described, in which there is a fixed amount of money to take care of a population and not an expectation then to turn around and charge on a fee-for-service basis as different services are provided, it allows for a serious reconsideration of who, what, where, and how care is delivered. It basically allows one to sort of think about how do you maximize the value of the money you have to be able to take care of that population. And so this allows for things that have now become a little bit more common because of how COVID accelerated and catalyzed the world to rethink some of the ways that we need to deliver care. But KP, you'll not be surprised to learn, has always been in the vanguard of thinking about how to provide services not only face-to-face, which was clearly the dominant model in that environment as well, but to also provide services in a non-face-to-face way, and to think about, are there efficiencies that can be gathered that way that we're all becoming much more familiar with through the use of telehealth in the COVID era and so forth. The other thing that KP, I think, has really kind of championed, if you will, that again is very much now becoming a prominent part of how we all think about care, is taking some of the resources and not just investing it in people, but to also think about whether significant investments in information technology can become a way of allowing for more efficient and effective ways to take care of a population. So there have been significant, and I mean significant, IT investments for a long time at KP to support communication, coordination, a means for clinical assessment, a way to measure value, and a platform for learning. And I'll try to show you some examples of that to give you a sense of how that emerges in the KP environment. Some of you may know or may not that Epic, which I know can sometimes sound like a dirty word in certain settings, but Epic basically became a company because of its work with KP. KP many years ago worked with this little company that pretty much no one had ever heard of at the time to develop the IT, to develop an electronic health record, and sort of Epic cut its teeth in its relationship with KP, and then over time that really has become a model for how electronic health records become a dominant part of the healthcare environment. The other thing I want to emphasize is how much the relationship of having the medical group only working with a single health plan is also something that I think is very unique or special about the KP relationship. One of the challenges I think that physicians often talk about as they try to aim toward different kinds of clinical goals and quality goals and so forth is that they, in a multi-payer environment in which there are patients who are covered by different health plans and so forth, there can be different signals coming from those different health plans about what the expectations are. And of course, by having the medical groups only working with one health plan, there's a very strong alliance in terms of what the strategic goals are that the health plan expects, as well as what the physicians then know what they're working towards. So this, again, I think allows for real alignment of incentives and work together with regard to goals and quality and so forth. So how is this flexibility that I'm talking about, the idea that you sort of get a budget to take care of a population and then to get to think about how you're going to use it, how does it get applied? If you stop and think about it here in the UCSF environment, there actually are at least two components of UCSF that have a similar kind of opportunity. One is what I experienced at San Francisco General, where a significant part of the budget for many years was a fixed amount of money that came from the city and county of San Francisco to the providers at San Francisco General to take care of the uninsured population. Now, it's changed a little bit because of the ACA and so forth, that more people are now covered by insurance, but there's still a sizable transfer of funds that come in a way that is not tied to a fee-for-service reimbursement, that allows for a reconsideration of how do we use those dollars in a flexible way. And the VA has some of the same thing as well, where there's a amount of money that is provided to the institution and allows for that kind of flexibility. So I think there are examples of that, and I certainly have drawn upon my own experience experience at San Francisco General as I've gone into KP to try to think about how do you use that flexibility. And I think what's key at KP and what we're continuing to try to strive for is it's wonderful to be granted the opportunity of the flexibility, but it's then what do you do with it? How do you in fact maximize the value and that opportunity? And so here are some of the ways that I think KP has thought about trying to do it. One is the use of group practice. And, group practice, I think, is a term that's probably familiar to many of you, this idea that, hey, we've got a multi-specialty group of physicians, we all work together. That certainly exists here at UCSF. But I think there are different ways that group practice can manifest itself. Some of it can be are there, in essence, parallel play going on where there are different expectations or guidelines or how care is provided, and whether that's shared in a common way across all the physicians, or whether in fact there are differences of opinion that in fact manifest itself in how care is provided depending on who you come in contact with the system. One of the things that happens in KP, or that is reinforced very strongly, is the use of developing a shared set of clinical guidelines that apply across all specialty areas. So, for example, you don't run into the issue that the radiologists and the general internists or whomever have a different opinion about when mammograms should start for women, or what the right screening methodologies are depending on the specialty group you see. And the way KP supports this is they have a very robust supported set of investigators who review evidence guidelines from AHRQ and other entities, think about their application to the patient population, and then issue that guidance in a widely disseminated way across all specialty areas. Now, none of the physicians are required in an absolute way to have to follow that guidance, but I will say that there is a strong feedback loop such that everyone is monitored in terms of when they adhere or don't adhere to guidance. I don't mean on a case-by-case basis, we'll call you into the office on a Thursday afternoon. I mean that sort of profiles are created and then discussions are held about when practice seems to be veering in a particular way away from guidance, whether that means guidance needs to change or what the basis of that is. So there is a strong culture of using a common way of approaching the population, particularly with regard to prevention and screening and those sorts of practices. But it applies to chronic care management as well. So that's one big part of how the flexibility is used in terms of applying it through group practice. Secondly, there is a very strong commitment to using a coordinated care model that is very much built on the foundation of primary care. I pulled out these numbers just to give you some context for thinking about this between KP and UC Health. So this is not just UCSF, but across the UC Health platform. And you can see that if you look at the physician specialty mix, across KP, about 44% of the physicians would be characterized as primary care physicians, whereas across UC Health, it's closer to 25%. So more investment in a primary care foundational model through KP than in UC Health. Again, lots of reasons that you could understand why, but certainly part of how KP has thought about this. And KP's distribution is probably more consistent with what you see in many European countries with regard to their specialty mix. There's also using that IT backbone that I alluded to. There's a strong set of mechanisms in place that allow for completely sharing of electronic health records, much like you're increasingly experiencing today, that allows for curbside consultations in real time, as well as sending referrals in which there are shared notes and the like. Another thing that I think is quite striking is the degree to which, because of the volume of patients and how they're managed across the system, there is a use of high volume proceduralists, right? So that there are just so many cases that come through of different types that individuals who do procedures do very high volumes of them. And I think you're all familiar with the notion of the volume outcome relationship, such that in general, practice does contribute to making perfect in many aspects of medical care. And so that there is kind of a built-in use of high volume proceduralists as a way to reinforce high quality. And this also plays out in terms of the regionalization of tertiary care services, so that not every one of the KP hospitals might offer tertiary care services like CABG surgery or more extensive tertiary care services. They're regionalized. And again, this contributes to practitioners who end up doing very high volumes of those procedures. And hopefully, I believe it does contribute to reinforcing high quality standards. And in terms of the importance of the primary care model, I think there was just a recent study I happened to come across and wanted to pull out to reinforce, I think, some of the value that has been identified with regard to using primary care as a foundational piece of one's delivery system. This is a study that came out of Hopkins that was published recently, in which they looked at across the U.S. 676 U.S. healthcare systems and categorized them based on their specialty mix, whether they're teaching hospitals and the like. And basically, we're trying to understand the overuse of unnecessary procedures. And they first had to go through the step of defining what is unnecessary. They relied on AHRQ, U.S. Prevention Services Task Force, Choosing Wisely, some of the entities that have identified things like, gee, it's not useful to do MRI studies in general for low back pain, or screening elderly patients over the age of 85 with mammography, or unproven surgical procedures like hysterectomies for benign disease and so forth. So these are just examples of the kinds of things that they were looking for as telltale signs. And what they found is that the higher percentage of primary care physicians as making up the workforce in these health systems, the less likely it was that these procedures would be undertaken. And consistent with that, and what I showed you about KP's primary care mix, KP was they then rated the health systems based on different quintiles of how much they did this thing, and KP basically came out in the best group in terms of not doing overuse. Again, consistent with the primary care foundation. The other thing that KP does has made a big investment in is patient engagement. And one of the things that really struck me is they make use of a website, kp.org. You're welcome to check it out. But they use this as their kind of portal of communication with the members. And what's striking is, for such a large organization and that takes care of such a diverse group of people, they've actually gotten an extremely high penetration of members registered through kp.org. So close to 85% of the members have registered, sort of gotten the equivalent of a username and a password and have logged on and so forth. And 94% of those that got the username and password have actually accessed the system in the last year. And why do they do this? Well, they do it in part to get information and educational materials, but this is how appointments are mostly done. So rather than sort of calling up the clinic and saying, can I get in and so forth, basically you book appointments very similar to the way you would go on to, Kayak or any of these websites to book a flight. So it's very user friendly in terms of doing those kinds of things. There's also now a 24/7 virtual care with a physician at any time, no matter where you are, that basically has a response time of just a few minutes. So these are very important assets for members, and is part of why, in fact, they sign up at a great degree. Medication refills were also handled this way, where you can basically just pull down on a scroll down, find your medications, and decide whether you want it mailed to you or pick it up or things like that. And then I think one of the most exciting parts of what's developing is some of the work going on in remote monitoring. And again, this got accelerated during COVID because of how innovative we all had to be with regard to changing the delivery model. And I just wanted to share this model with you because I think it's really one of the exciting examples of how telehealth and digital health are coming together to actually improve the care experience, and I believe will improve outcomes as well. We are studying this, but we moved to a model in KP of basically in the prenatal period. So when mom's pregnant and needs to have visits, of course, the traditional model is, mom's coming in every month to go to the OB and get checked out and so forth. And we now do the vast majority of prenatal visits, or we offer the opportunity, and most women want this, to be able to actually have their prenatal visit happen while the individual is at home. And part of what we do is at the very first visit, they're given an app that then supports the use of a digital blood pressure cuff, a digital scale, and a fetal Doppler, basically. And during these visits at home, data has already been downloaded about blood pressure and about weight that mom has been, sending in every day. And then the Doppler is done while, the doc is on the phone with the patient and so forth. And this has resulted in detection, not surprisingly, of more women at higher risk for preeclampsia being identified sooner, right? So unlike, the possibility of do we happen to find the high blood pressure when the patient is in the office, we now have much more continuous monitoring and engagement with the patient that is really contributing, I think, to a much more successful model of identifying high-risk individuals. This started actually in our Georgia region, where we have a somewhat higher penetration of African-American patients. And I think you're all familiar with the really horrendous situation with regard to maternal deaths and morbidity associated with pregnancy around the United States, and particularly among African-American women. And so this was really developed in part to become more effective at identifying these cases. And I think it's what we've discovered is that it's not only more effective in that patient subpopulation, but also more broadly in terms of taking care of moms throughout KP. And so we're on a schedule where this started off in Georgia, and then we're now spreading it across all of our regions, and we'll have this basically in place in all of our regions before the end of the year. The other thing, of course, that really plays into the flexibility of how KP thinks about using its resources is the fact that we have a longitudinal population. It's not just a longitudinal population, but it's that we're taking care of the whole patient in a longitudinal way over time. There are KP members, there are many who have been with KP for 30, 35 years and so forth. The average is a little over 11 years, which contributes to a real sense of a commitment to the patient and vice versa. The majority of care is happening in KP delivery sites, so we're capturing that data very effectively. And then there's a very active process of repatriating data that of interactions, encounters that happen outside of KP that allow us to sort of continue to get the whole picture on our membership about the care that is provided. But my point is that, again, if you're thinking about how do you maximize value for the population, there's a real desire and an ability to try to capture and identify where your prevention interventions return value to you. One of the things that is said about the fee-for-service system and the degree to which patients move across different health plans is that it's very hard to sort of know whether the upfront investment in screening or prevention will ultimately save you money later on, or will the patient, you spent the money on the screening, but then the patient is actually discovered with the disease, in another health plan and so forth. And so the trade-off is a little harder to see. And I think we're in a little bit better position to be able to kind of have direct sense of that. And we've done some of this kind of work where we've kind of looked at what are the costs of different kinds of cancers at different stages. So what I'm showing here is just some work that was published that looked at, above age 65, below age 65, breast cancer screening, colorectal cancer screening. What are the costs for 1 year versus 5 years? And, it's not, without having to squint your eyes, it's not going to be surprising to know that it's much more expensive if the individual is younger because they have more years in front of them, but also if they're diagnosed at a later stage, because then you are having to do a lot more complicated treatment to take care of them. So this feeds into the mentality at KP to really invest heavily into prevention and screening. And so on the right-hand side of the slide, what I'm showing you is some of the screening rates across the KP enterprise, and that you can see that I've listed the HEDIS national 90th percentile, so that corresponds to nationally what is the 90th percentile best performance in these different areas. And you can see that for screening, KP basically performs at or around or a little bit better than the 90th percentile in screening. It's very much built into the DNA of the organization, but I think part of the reinforcement for that is the ability to see the return on investment and the savings that accrue related to finding individuals at an earlier stage of disease, so that in fact it can help to keep costs down. So I want to turn now a little bit to sort of what is new, and in a way what sort of attracted me to go to KP that is sort of my responsibility to help to lead in that setting, to give you a sense of where I think KP is headed with regard to quality that might be useful to be reflecting on here at UCSF as well. So KP, has a mission statement that's probably, I can't remember the one exactly anymore from UCSF, but, obviously a tremendous pride and commitment in the same way that UCSF does to want to really drive for superior health outcomes. There's a great emphasis and commitment at KP to not only drive superior quality, but also an enhanced focus on equitable outcomes. And so what I would say is the kind of the bottom line of what I'm being asked to think about on a day-to-day basis in my role as the chief medical officer and focusing on quality is, how do we measure and demonstrate the outcomes that we're getting from all these processes that we're performing? Are our outcomes truly superior in these different areas? And secondly, even when we're overall doing very well in our outcomes, can we demonstrate that these are equitable by different subgroups, whether that be by race, ethnicity, or other kinds of characteristics that are important to look at in our population? So as I came on board at KP, one of the things that the board directed KP to do is to take all of the measures that are used in quality, and there's frankly about 400 that we monitor regularly, but that also includes all the regulatory ones of HEDIS and CAHPS and so forth. And all of those we collect and report through the lens of race and ethnicity. So we are basically always reporting out and providing. And so in fact, in our work with Covered California, we're the only health plan that has provided our data on quality, on HEDIS by race and ethnicity. And this is the movement that I think is actually beginning to spread throughout the country. We are hearing from NCQA, who is the steward over the HEDIS measures, is starting to push organizations to start to look at different measures through the lens of equity. And this is something that we feel very strongly about. And the other aspect is to really try to capture and incorporate key social factors, not just race, ethnicity, or sexual orientation, but other aspects of housing stability, food security, and so forth into the assessment of outcomes, and making that a routine part of our data capture so that we can understand how it influences outcomes. So we're very committed to these issues and are not only trying to do it in our own backyard, but to try to figure out how we can contribute to a national conversation about trying to do this and making this routine for all health plans and delivery systems to be able to do. Something I want to really emphasize about the KP culture, and I think it's kind of an interesting contrast as I've kind of thought about it, about what's sort of different and rewarded in some ways. And I would say, one of the things that I just loved about working at UC is just how visionary so many people are here in terms of just incredibly creative, innovative ideas about how to bring about changes and improvements in healthcare. And I would say at KP, there's also a great admiration for vision and these kinds of ideas. But more than vision, even, I would say that it is execution that is celebrated through different kinds of award systems that they have within the organization, and that there's a real commitment to guaranteeing performance in terms of how the health plan works with different kinds of people who are the customers that are paying for the service. And I'll show you that in a moment. And one of the most common things that my boss, the CEO, Greg Adams of KP, says is hope is not a plan, that there's a real engagement in not just are we going to have a great idea, but how are we going to execute on it and commit to that's what we are going to absolutely deliver. So there's a real strong sense of that. Yes, let's have an innovative idea, but it has to be something that we can operationalize and, in fact, make consistent and reliable across KP. So that kind of execution component of it is something that's really heavily emphasized by the organization. Part of how KP does this with regard to quality improvement is that it has made really large investments in its people with regard to getting quality improvement training. There's been a long-standing relationship between KP and IHI, the Institute for Health Improvement, with Lean, with a whole bunch of different kinds of trainings that allow frontline, basically the entire staff is really trained in these methods, and it's very much in the air vents of the organization in terms of its commitment to these ideas. I referenced that there are awards that are given out on an annual basis, and these aren't just sort of like someone gets a trophy and quietly goes off somewhere and a little announcement is made. The entire organization comes out for this, and it's a very long and arduous, rigorous process of evaluating a set of nominated innovations of improving quality each year that are then celebrated. There's one big award for quality improvement and one big award for safety improvement. And the idea is to both recognize the vision of it, but the execution of it and how it will leverage spread, because these are often developed, say, in one region and then spread throughout the entire platform of KP. The other thing is how strongly the research enterprise is tightly aligned with the clinical operations, and a real commitment of a culture of aligning implementation of operational changes with learning about them in a real-time way. And some people have referred to this as a learning health system, which I know is gaining a lot of momentum here at UCSF as well, but really thinking about, okay, we're thinking about making an operational change. How do we learn in real time about that? And one really stunning example that I became aware of when I went to KP is the work that was undertaken to basically bring down the length of stay related to total joint replacements, such that now the majority of people who get total joint replacements don't stay overnight in the hospital at all throughout KP. And basically, so this was an idea of an orthopedic surgeon down in the Southern California region. He basically designed the ideas of how to both standardize which joints are used in the operating room, all the actual flow of work within the clinical environment, but also the flow of work of what would be required to be ready at home when the patient would go back home the same day to be able to accommodate for them. And the reason I put up this example is because it also went hand in hand with a set of research studies. This is just from one of them that shows the steady decline down in the length of stay, which is now averages under 1 day because the majority of people don't even stay in the hospital. But it also, not surprisingly, you start to have a reduction in other kinds of hospital-acquired complications because the patient isn't even staying in the hospital to get this done. So this is something that is very much in the fabric of how KP tends to approach innovation. It's about sort of taking an idea, but really trying to learn and to figure out the workflow and spread of it within that environment. And again, I think that's something that is of growing recognition here at UCSF as well. the other thing I think is interesting is how KP engages its customers. So basically, one of the things that KP does is it does create financial guarantees for its performance, and so that substantial amounts of funding is put at risk in its contracting with employers, and a big chunk of that is tied to clinical performance. So how we do on some of these HEDIS indicators and how we're doing with regard to equity is becoming a big part of what is put in these performance guarantees. Employers and customers are also given direct access to their own data that they can then play with and manipulate, look at, analyze, and it is benchmarked against the performance of other KP members from different employers and so forth, so they can engage and understand. So this is a big part, like during COVID, we were able to give profiles to each of our customer employers to say, gee, this is the average rate of vaccination among all of our members, and this is what it is among your specific employees who are members with us. And we provide those sorts of profiles. We don't necessarily say it's John Smith who didn't get his vaccine. They can figure out those kinds of things if they want to do that, but we allow them to understand how their performance among their own employees is compared to what we're seeing more broadly. And at the bottom of this page is a quote from someone who's at JP Morgan, who is one of our customers, talking about the availability of the data and how they can utilize that in their own interests in trying to promote equity of outcomes among their employees, and how the ability of providing that data has been important for them in their partnership with us. Finally, I just want to touch on something else that I think is really kind of innovative and exciting, and that is, I mentioned that KP is a nonprofit health plan. So as a nonprofit like UCSF, there are community benefits that need to be provided back in lieu of the fact that taxes are not being generated related to the nonprofit aspect of the organization. And KP has approached this like it has done in many other areas in a very broad, systematic way that really tried to think about infrastructure. So it developed something called Thrive Local. You may be familiar with KP uses in its advertising campaign to thrive. So Thrive is a commonly used word in that environment, in the KP environment. The Thrive Local is this notion of creating a digitally integrated network of community services in each of the communities where KP is located, so that members can, through digital connections, if they want to go on that kp.org that I referenced earlier, they can find out about the resources of the different types. It's a curated network, and directly communicate through kp.org to be able to try to access services. This can also be facilitated through their engagement with our call centers if they want to be screened and facilitated to get that kind of connection. And it can also happen in the doctor's office, where a physician may learn about a patient who with diabetes who's got food insecurity, figuring out where that patient lives and then connecting them with the resource in their community that might be able to assist with taking care of that social need. So what I think is very exciting about this is that it's kind of an efferent arm, if you will, of addressing social determinants of health, and something that I think has been a very clever way of thinking about using the community benefit. So I guess I'll wrap by saying, is there a better way to be able to organize and deliver healthcare services? That was the question these two guys asked together. These two guys are on the right-hand side. That's Henry J. Kaiser, whose name is associated with the health plan. He was really became most famous in the United States for his work in the shipyards, which I touched on. He was always trying to think about, is there a better way of doing things? During World War II, he famously changed shipbuilding, which was typically about a years-long process, in which the Nazi Germany was able to sink U.S. naval ships at a much faster rate than we were able to build them. And he basically recreated the working process so that these ships could be created every 5 days. And so that you can imagine the individuals working there and how they're working, but he wanted to have a way to take care of his workers. So he contacted the individual on the left, whose name is not Permanente. This is Sidney Garfield, who was the innovator innovator of the idea of using the prepayment model, of using group practice, focusing on prevention, population-based approaches, and even started to think about the record keeping that is the basis of the clinical information technology. And I think, frankly, these were all great principles from the beginning, but I think the magic of it, as I've tried to highlight here, is the flexibility it creates to allow innovative ideas of thinking about how to deliver services more effectively and efficiently, and ultimately to maximize quality of care. So thank you very much for listening, and it's been a great pleasure to share my journey with you.
Great, thank you. Fabulous. It's exciting and inspiring, and I'm a little jealous. So let me start with the jealousy. If you were UCSF, knowing what you know now, and we can't, the prepayment environment we don't own really, it's sort of, we are paid the way we are paid. What would you now recommend that we do to be better than we are?
Well, first of all, I mean, UCSF already does have a great commitment to, improving, innovating, and so forth. I think the one thing that I would say that UCSF was building its capacity as I left, and I think I would encourage, is what I was trying to emphasize with regard to execution. I do think that UCSF is just a fountain of incredible ideas. I mean, everyone you meet with at UCSF, you're always like just dumbstruck with how clever people are about innovation and so forth. But I do think that if you don't give equal attention to the execution and making sure that those who could benefit from the innovation are real, thinking through the workflow and how to execute it and so forth, that there's a real loss, and that's where I think there is some missed opportunity. And so I guess I would really encourage to try to think about how to build those kinds of systems into UCSF. And I will say that part of that comes it tends to take an investment of people who are really designed and thinking about doing that part of it. It's often not the person who innovates and comes up with the idea who's the best person to operationalize and to execute on. And it's trying to think about how to do that partnership together that I think could perhaps provide some opportunity here.
Great. I'll ask one more, then open it up. Physician culture. So how you now have a medical school, but prior to that, people were trained all over the country. They came into KP. How much work is it to sort of integrate in the culture if they're giving up some autonomy to be part of this group and accepting group regs and norms, which is not sort of a normal thing for physicians to do or do comfortably? So how much work does that take? How much intentionality is there? How much of that is related to the way they're paid versus sort of the culture?
Yeah, those are great questions, and I wish I could tell you for sure I knew the answer. I will say that I think there is a real strength that comes from the group practice culture in the sense of feeling like people are in it together. And I've seen this very much during COVID, during the time that I've been there, of the great sense of kind of teamwork and cooperation. There's something at KP that I got to witness at San Francisco General when we really started moving to our electronic referral system, which was the connection of physicians in communication with one another in the shared care of patients. And I think it was both satisfying in terms of what could be achieved for patients, but also the learning that would go on between physicians. And I think that is something that really reinforces the culture and what makes it satisfying to practice in that regard. There could be a certain self-selection that takes place in terms of the choices that people make in terms of where they want to practice and so forth. But I do think that there's a lot of thoughtfulness that goes into how the process of the guidance that I referenced is arrived at, that people buy into it in a collective way. There are lots of ways that the physicians are given a chance to feel like they are contributing to the rules, if you will, that are guiding them. And I will say that what's quite remarkable is it's an integrated health plan and a medical group, but once the relationship is established, basically the medical group drives the clinical decision making. It's when there's a time that a physician feels like they need to do something that's outside of the guidance, they're not asking permission from the health plan. I've never consulted on those kinds of things. This is up to at the end of the day, clinician is asked to make the best choice for their patients. But I think they feel like they have a team behind them that they can get that advice and to weigh that decision if that makes sense for them.
Great. Bring the mic out.
Yeah.
Thank you, Andy. Great talk. Thank you. Mitch Feldman from DGIM. It seems like the vision you present, or the model, the economic model you present with a fixed payment for, take care of a population of patients, is potentially sort of nirvana for primary care doctors. Finally, the ability to shift from volume to value.
Yep.
Doctors don't need to be in cranking out patients, can get off the RVU hamster wheel and figure out how to best manage a population of patients.
Right.
But it's not clear to me that the clinical model at Kaiser has really shifted to that. My understanding is docs are still primary care docs in clinic 8 to 9 sessions a week. I think they're burning out at about the same rate as primary care doctors are nationally. So I'm just wondering what the thought, why can't Kaiser shift to a model where doctors are spending more time caring for populations rather than continuing to crank them out in the clinic? And, and kind of connected to that is the huge growth in the virtual care, the demand from patients to be cared for, not in the office, and the huge burden that's placing on docs nationally. I'm wondering how Kaiser's responding to that.
Yeah, well, thank you, Mitch. I mean, these are really important questions. And I think the last part of your comments really plays into it, which is what's happening from a consumer perspective is that these new modalities, whether I can email my doc, I can, instantly chat with my doc, all these kinds of things are something that consumers really want. They are trying to figure out how to get healthcare to be focused around them, to be patient-centered, if you will. And we, of course, value and want that. But it does come with a whole new set of demands, right? So one of the things that we're asking ourselves that I think you're raising is, okay, if we open up more of these modalities where people can contact their doc through multiple ways, does that relieve the pressure of face-to-face visit by being able to do that, or is it just like another thing that we have to do? And I think that it's probably a mixed picture depending on either the needs of the patient or different kinds of circumstances. And I think we're still really learning about how to kind of navigate that from a system perspective. So I don't know that we've hit on the nirvana of exactly how to do that yet. We are doing exactly these kinds of studies, those of understanding, how do you help people get in the right line, if you will, whether they, could get their problem managed through, an asynchronous text or something versus needing to come in face to face and not have it just be redundant and extra work and so forth. And I think it's also about creating the team around the primary care doc so that not all of it is necessarily physician generated as well. So great question. And it's one we are clearly putting a lot of energy into trying to sort out, as I'm sure you're thinking about as well.
I think we just have time for one more from online.
A couple of online questions rolling in together basically are about equity. Does the Kaiser member population reflect the demographics of different states? And what are the barriers for more Californians or more Americans to have access to these type of healthcare systems, including those with, ACA, Medi-Cal, et cetera?
Yeah. Great. So in terms of the diversity of the population, Kaiser looks a lot like the communities where it is based, right? And so, when you're over in Oakland, you see, in fact, a slightly larger demographic of African Americans than you do in San Francisco and so forth. Different regions have, different mixes as well. In our Hawaii region, we have a substantial number of, Hawaii Pacific Islanders and so forth. So, but it is quite a diverse population. And in fact, one of the things that I didn't highlight here today, but it is super exciting from my perspective, is that actually UCSF was involved in generating this. Neil Risch, who many of you know, started with KP many years ago a biobank, and there are now 400,000 samples in that biobank. And I think worldwide, most people recognize it's probably the most diverse biobank that has ever been assembled. And there are some really exciting opportunities to understand genetics and genomics in a much more diverse population. So this is something that I think will really be some added value, because some of the other ones that have existed have been in overwhelmingly white European population. So I think this is an important aspect of things. KP is also has seen a very large increase in its Medicaid footprint during COVID. Many people who lost employment. I don't know if you know that KP has a very unique thing with regard to Medi-Cal here in California, which is that if you had KP insurance through your employer and then you go on to Medi-Cal because say you lost your job, you're actually able to stay with KP. So that one of the burdens that's relieved on individuals is, oh gosh, not only I lose my job and my insurance, but now I may have to change to another one. So this
Forever or?
yeah, you can continue on with KP. So it's actually it's similar to what exists in Norway, where the multi-payer system doesn't require you to change who your medical group is. So that's a really nice aspect of being able to do that, and it's led to KP having a growth of close to 200,000 new Medi-Cal members during COVID because of these kinds of shifts and so forth. I think you had one other thing that I may have overlooked, but no, I got it. Okay, awesome. Thank you. So
We unfortunately have to quit. We're
Okay.
over time.
Okay.
Thanks very much.
thank you. It was great.